Okay, well, welcome everybody. This is a session for monitoring for and treating thyroid cancer in survivors of non-thyroid malignancies, as well as transitions, helping young survivors understand and begin to manage their thyroid cancer. So I'm happy I have the opportunity today to let you know who's going to be speaking. So we have Dr. Sogol Mostoufi-Moab, and she is a pediatric endocrinologist and oncologist at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. She treats childhood cancer survivors with endocrine abnormalities such as abnormal growth, thyroid disorders, pubertal disorders, and thyroid malignancy. Her research program focuses on bone health and body composition abnormalities in childhood cancer survivors. Her dual training experience provides her with unique expertise for treatment of multiple complex endocrine abnormalities after various childhood cancer regimens, such as high-risk neuroblastoma treatment. And also happy to welcome Dr. Katherine Denauer. She is a pediatric endocrinologist and clinician at the Yale Pediatric Thyroid Center in New Haven, Connecticut. She earned her undergraduate degree at Dartmouth College and her medical degree at the University of Vermont College of Medicine. Dr. Denauer completed pediatric residency at Walter Reed Army Medical Center in Washington, D.C., and pediatric endocrinology fellowship through the National Capital Area Pediatric Consortium at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. Since 2006, her clinical practice has focused on pediatric thyroid disorders, with particular interest in Graves' disease, thyroid nodules, and pediatric thyroid cancer. She was a member of the American Thyroid Association Committee, which created guidelines for the management of thyroid nodules and thyroid cancer in children. And lastly, we welcome Dr. Aime Franco. She's an assistant professor and investigator with the Center for Childhood Cancer Research at Children's Hospital of Philadelphia. Dr. Franco directs the newly established Pediatric Thyroid Cancer Translational Research Laboratory. She earned her PhD in cancer biology from Vanderbilt University, Nashville, Tennessee, and conducted her postdoctoral fellowship in genetics of thyroid cancer at Memorial Sloan Kettering Cancer Center in New York. Her research interests include the molecular biology and genetics of thyroid cancer and improving quality of life and survivorship outcomes for thyroid cancer. Dr. Franco is a recipient of a ThyCa thyroid cancer research grant and has spoken at many ThyCa conferences. So welcome everybody, and thank you so much for being here.
Well, thank you so much for that introduction, and I'm going to try to share my screen and hope that this is going to show what I want it to show. Thank you. This is really, it's kind of in a strange environment to be presenting to you guys today and not being able to see faces. I love coming to ThyCa and being able to interact and really kind of gauge how everything's going. And I'm not used to actually presenting at ThyCa with slides because usually I like to just engage with the audience. But I wanted to start this session off. We're talking about transitions, and I myself am a thyroid cancer survivor. I was diagnosed at the age of 23, 22, 23. It was a while ago now, so cusp, but diagnosed with follicular thyroid cancer. And I was one of those many where all along the route, all along the way, was told, don't worry about it. There's no reason that this is going to be cancer. People your age don't get cancer. Young people, young women, at that point, they didn't think young women would get thyroid cancer. Boy, were they wrong. But that journey started very early in life. And I was kind of at that awkward age, not really a adult yet and not really a kid, being at that young adult cusp. So I say that because I think that this is a challenge. And as we talk about pediatric patients, and especially those patients that are diagnosed at the end of pediatrics, as they're getting closer to the cusp of being a young adult, it's really tough. And it's very difficult as a child, as a young adult, being told you have cancer and really being thrown into that spotlight. You want to make decisions, but at the same time, you're scared to make decisions. I find myself even now, 20 years after diagnosis at times, hesitant and not wanting to make decisions. I say that for the parents in the crowd and also those of you that are at that cusp. It becomes very challenging. And there's always kind of this internal battle between wanting to be independent and wanting to make your own decisions, and then at the same time wanting to really defer somebody else to have to make those tough choices. But when I was diagnosed, I was a biology major. And quite frankly, I thought I knew it all. I was able to ask a lot of big questions because I was doing a lot of this. I was in the middle of college in my senior year, getting ready to hopefully go on to a PhD. And it was a real struggle. And I say it because it was a struggle for me, but also a struggle for my parents, because they tried to give me as much autonomy to make my own decisions as possible. But it was also very difficult at times because I was asking questions that they didn't understand. Sometimes I probably didn't even understand the questions I was asking because I knew a lot of big words from what I was doing in college and at the time. But it is a difficult hat to wear at times. So for you parents out there, I say that because be patient. It's not necessarily us trying to be defiant. It's trying to just figure out how all this is going to work. And it was really tough to think at 22 as I'm in college and I'm thinking more about, you know, the tailgating parties and what's not going on or what is about to be going on and how I can and can't participate in that due to my own diagnosis. So it really was very much a struggle throughout. And it really at times created conflict. And I think that maybe I certainly wasn't prepared for it. My parents weren't prepared for it. Nobody prepared us for the conflict that would come about with managing my own care and who should be making the decisions. And clearly I was an adult and in the role to make my own decisions. But I really was still in college. There were things that I wasn't thinking through. There were things that I couldn't foresee for my own future at times. So, you know, patience, I think, is the key. And as much as you can prepared for this struggle and the issues that arise, because it is tough and it's tough on both sides. And my parents and I actually continue to this day have this struggle because I don't tell anyone when I go for follow-up care. No one knows when I go in for my yearly, I still have ultrasounds, when I go in for my, you know, medicine checks and things like that. That's a battle that I take on my own and something that I do completely independently. And it was only for the first time, probably within the last 2 or 3 years, that my mother and I even started to talk about it. And she started to tell me how difficult it was for her. And I never appreciated that. So there's very much, I think, in this young adult world and in the pediatric world, there's absolutely two patients or two sets of patients, the patient itself and then the parents and the caregivers. And I would argue the family members. I mean, for me now, it's my kids that are part of not necessarily the decision making, but my decisions absolutely impact them and how we handle care, how we talk about things, and absolutely impact my husband. So I think at times that's one of the things that I was never prepared for in this journey, especially being diagnosed as young as I was, of how many people my own diagnosis and all of my decisions would impact. It wasn't just about me. And on the flip side, you know, my parents, and as they helped and guided with decision making, it wasn't, they had to think a little bit more broadly. It wasn't decisions for me in the immediate future, but you know, we started thinking about, well, how is this going to impact her having children in the future? How does this impact fertility? Those questions weren't necessarily ones that were at the forefront of concerns at the time, but they absolutely were questions that needed to be addressed and talked about. And sometimes they weren't comfortable, and we didn't want to talk about them. For me, and I think this is really important for parents and anyone in the pediatric or the young adult. So often thyroid cancer is talked about in such a positive fashion because most of us will not die from the disease, but your world changes. You have a before the C word and an after the C word. And as soon as you hear cancer, your world is upended. And for me, my own personal struggles, I didn't want to be defined by the disease. I hid it from my friends. I hid it from telling people just because I wanted to be a 22-year-old, a 23-year-old. I did not want to be a cancer patient. And each of us face that unique and independent journey through this. So I think there is no right way to do it. I wish and I hope now that there's a lot more support. I didn't know anyone my own age going through a cancer diagnosis at the time. And I felt so alienated. And I think that's what's so difficult, and being able to find groups and those, whether it's the same cancer or it's a different cancer, just those that understand some days you want to crawl in a hole and feel sorry for yourself, and other days you want to wear a turtleneck and pretend you never had thyroid surgery and make sure none of your friends know that you had it. The other thing, and I mean, I've already talked about this and kind of hit on it, is that even when I was 22, 23 years old, there were some things that I absolutely wanted and knew how to make decisions about. And there were other things that I absolutely needed help. And I needed parents to lean on. And even though I was technically an adult, there were no physicians and transition care for me available at that time. I was too old to be, I never saw a pediatrician, and part of this, but too many of the physicians and the not oncologists, but endocrinologists and doctors I was dealing with only treated adults. They had no idea what to do with a 23-year-old. They were used to treating 45, 50, 60, 70-year-old women and men and had absolutely no idea how to talk to a 23-year-old. So that became very difficult. So I think it's just something to think about as a patient, and it's okay to push back at times and to ask more questions, and don't be afraid of that relationship. You have to be your own best advocate, and parents have to be their own best advocate for their kids at times, because it is, unless you're at a major center that has the specialty in thyroid cancer, a lot of times you're not seeing specialists that are dealing with this all of the time. So that's one thing that those of us that are treated, and I was initially treated in the community, have to deal with. So I think, you know, I wish I'd known about ThyCa sooner. I think having those relationships and having those people to talk with make the journey so much easier, and at least having somebody that knows what it's all about, and can say, I don't know the answers, but yeah, this sucks and I'm going through it too. So much of the time, just having someone else that understands what you're going through can be so much more helpful than even those that have answers. I would say thyroid cancer, the other thing, I think too often in cancer, I think thyroid is unique. There's a before cancer and there's an after cancer. Thyroid cancer in my mind is it's a marathon, or it's an ultra marathon. It's a race that never ends, especially being diagnosed in young adulthood and having your thyroid removed at 22. I'm almost at the cusp now where I've had my disease longer than I didn't have my disease. But those of us that are diagnosed young, we're going to live with our disease for a lot longer than we're ever going to have a life before that disease. Whereas many cancer patients don't necessarily think in that manner. So I think that's something that's very difficult sometimes to deal with. And we have to manage it for the rest of our lives. Management gets exhausting. I was sharing with Catherine, we were talking about it, here I am, and I do this for, not only am I a survivor, but this is my life. I run a thyroid cancer research lab, and I work with the best thyroid cancer experts in the world. And I'm coming up on the point where I realize that it's time for my next yearly appointment and blood work time and renewing all of my prescriptions. And oh crap, I have to set aside the time to do that. It just gets really challenging and exhausting. And you think about it every day, because when I wake up, I can see my scar on my neck. So there's the constant reminder, but at the same time, I don't necessarily look sick. And sometimes you want to just kind of forget about that part of your life. So be patient with yourself, and understanding that the management is exhausting. And what is normal? So I can't tell you what normal is anymore. I hate when we talk about, do you feel normal? And that's one of the first questions I get when I go, and how do you feel? Well, I don't know. And I don't know how I'm supposed to feel, because honestly, I never remember feeling and what it felt like before when I had an intact thyroid, and when I didn't have to rely on my Synthroid pill every morning to set my thyroid hormone levels. So it's hard at times. And I think that's part of the exhausting thing as well, is trying to figure out that balance and that rebalance and the changes that happen. And I say there's still a lot of unanswered questions. I think putting on, again, well, this whole talk has been on my patient hat, but I think this is where it's so important for us as patients to continue to talk with each other, talk with our physicians, talk about the challenges that we face, because I think for too long we became dependent on blood work and blood tests, because this was supposed to be a disease that was easy to manage. If we give a thyroid pill every day and blood work looks normal, then we've cured our patients of disease. And I don't mean that as insulting for my clinicians there. I just think that, you know, too often we look at cancer, and in many other fields, cancer is looked at as, do you die of it or do you survive it? And as long as you survive, then you're on the other side of the disease and it's great. But thyroid is so different because it becomes a chronic condition for the rest of your life after you've had it and after you've had your thyroid removed. And I think we need to address it. And that's why I got into the research space, because I wanted to address this as a chronic condition and realize that it's not just about being alive, it's how I can live. And that's just as important, and actually more important for those of us that were diagnosed at pediatric age and as young adults, because we got a long time ahead of us dealing with this chronic condition. And we need to be our best selves and have our best lives moving forward. And just being alive and surviving the disease is not enough. So I've gone too long. I'm sorry, Catherine, I'm getting into your time. So I'm going to stop sharing, and I'm going to encourage people to please start putting things into the question and answer so that we can have some dialogue. And thanks for letting me share my experience with you.
That's great, Amy. I think your part of this for me is really the most important part. So let's see if I can share my screen. Okay, and let's go to the beginning. Hopefully this is going to work. Okay. So I think actually what you just said really, I think, is going to make my talk hopefully even better, because I think hearing your voice as I speak is going to be really, really helpful and sort of help what I talk about make a little more sense, perhaps. I think really your real world experience is really so important, and it actually really teaches us as clinicians so much, and it really does affect things that I think about doing in my own practice. So, so continuing on this theme of transitions, my plan is to basically define transition. I think we know this is a journey, and you're on a road, and sometimes that road is windy, and sometimes there are bumps in the road, and Amy's already alluded to that. So I want to talk a little bit about what is a transition, and then talk about, just sort of raise awareness of some of the things we consider as we help patients transition from the pediatric realm over to the adult realm, some of the barriers and some of the logistics to think about. There are a lot of things that we could talk about, and I'm really just going to kind of touch on things briefly and just to kind of give people some ideas and things to think about in their journey. And then I do want to talk a little bit about this issue of access to records. And I'm going to mention two things in particular. One is the Cures Act and the other is Hipaa. So in terms of defining transition, the Society for Adolescent Health and Medicine defines it as the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems. So breaking that down a little bit, when we're talking about child center or the pediatric system, we're talking about a system in which adults are primarily making the medical decisions. And then when we move into the adult-oriented system, we're talking then about the adolescent or the young adult patient as the one who's now making health decisions and choices. But if you look at that little chart on the right, I think what I want to sort of emphasize is that it's not an all or none thing. And I think Amy alluded to this, that the parents involved or the families involved, and then the patient themselves are involved, but they have different roles over time, and they sort of share that management. And Amy talked about that. She knew that sort of at some point, she's sort of the CEO of her care, as this chart talks about. It's kind of a business model here. She's the CEO of her care, but it doesn't mean she's the only person making decisions. And she can kind of look to her family as helpful consultants, perhaps, or part of her board of directors, if you will, that can help her make decisions when she needs that. And I think if you look at this shared management idea on the right, you can kind of think about that in terms of anything that we do as parents or clinicians in terms of helping children go from being the receivers of care all the way through to becoming managers, to supervisors, and then to basically in charge of their care. I mean, we're talking everything from brushing their teeth to getting dressed. How does that work over your lifetime to being in control of your healthcare? So thinking of it in that context, that it is a shared process. And then I do want to just highlight in this definition the words purposeful and planned, because I think those are key. A transition is not an overnight thing. It does take work and it's a process. And that's really what I'm going to emphasize in my talk today. It's more than just changing to a new provider. It's more than just finding a different doctor. There's a lot of logistics and sort of moving parts behind it and things to think about. So I think that's what I want to raise today. So why formalize this transition of care? Why make it sort of so official? And I have to say, this is kind of a newer field, if you will, in medicine, something that's been studied really just more recently or more robustly in the last few years. And I have to say, many of us, including myself as providers, are still sort of figuring out how we put this into practice in our own practices, and how do we help with transitions, and how do we make it more formal. But research has basically shown that this transition, having a process, is especially important for people who have chronic health conditions. And for those patients who don't go through a structured process, a lot of issues can come up. I mean, one is just that there's no continuity of care, and then things could get missed. I mean, of course, we don't want people to have recurrence, but if you have a recurrence, we'd like to pick up on that early and have a plan for it. If people don't have an idea of who they're being followed by, there's not a good transition to an adult side, they may end up using the ER for their care, and that's not optimal either. The ER may not have your full records, they don't understand this disease, and that could eventually end up leading to higher costs of care, or, as I said, other healthcare complications. So the idea is we want this to be a smooth journey if possible, and kind of showing that EKG on the right, we want your rhythm to remain stable, basically. So thinking about some barriers to transitions, I mean, there's a lot of barriers, and we could talk about many things for a long time, but I basically just want to highlight a couple of things. One is, I think a big barrier to transition is thinking about change, right? Transition is change, and when we start thinking about change, anxiety arises for many of us. And so the idea here is, I'll show you with my pointer, thinking about fear. So fear of who is this person that's going to be following me? What if they totally upend my current treatment plan, which I personally, maybe I really like my dose of thyroid hormone and I'm happy with it. You know, what kinds of things are they going to change that I may not agree with? Are they going to listen to me? How do I get there? How do I find the clinic? How do I make appointments? All these kinds of little things that add up to a lot of sleepless nights for some people. And we would like to try to avoid that. I think one of the ways to avoid that is with planning. So I think the key here is having a detailed plan, and a plan that's made over time. And then, oops, I'm still trying to find my mouse, sorry. And then the other issue would be system difficulties. So how easy is it for you to access care? Do you live in a more rural area where maybe resources are more limited? Do you have the clinicians you need near where you live? So thinking about some of those things too as you move forward. Again, I'm stressing that this is a process. It's not a set timeline. It's something that happens literally over months to years, really. And there have to be needs that have to be considered at the patient level, at the parent or guardian level, and also at the provider level. And then within those, thinking about those needs, then we can develop goals of what needs to happen from those different perspectives. What are the patient's goals? What are the family's goals? And what are the provider's goals? And really the idea is everybody should be working together to try to help promote independence. You can kind of think of it as sort of a stair steps, right? You're taking steps at a time, and sometimes you might take 2 steps forward and then you take 1 step back. I can think about just this week, I saw a patient who's 12 years old now. He was diagnosed at a young age with thyroid cancer at age 6. And we talked about how the family's been trying to have him take some responsibility for being in charge of taking his thyroid hormone. And they realized that he was missing a fair number of doses. And so that idea of trying to help promote self-responsibility, but maybe he wasn't quite there yet. And we had to kind of take a step back and think about health habits. Why are you taking this thyroid hormone? What happens if you don't take it? And then trying to move forward over time with that. When does this process start? Well, really, it probably actually starts at diagnosis. And I think we as clinicians try to plant the idea that, you know, thyroid cancer is a chronic disease, as Aime said. And so it's going to be a lifelong process. And so we start to plant that idea early. And then as time goes on, we'll have more specific discussions in the teen years and the college years, but in particular for those patients diagnosed in before age 18, we'll talk in more detail, I'd say, as they get close to age 18. And then actively transition patients, usually in that 18 to 22 year time frame. For some people, it might happen earlier. And for others of my patients, it's happened a little later. You know, for many people, age 22 is when they're graduating college. That's a time of a big transition in their life in many ways. They're starting a job, or maybe they're starting furthering their education. They may be, they're moving maybe to a different city. And so I've had patients where we've talked about making the transition at that point, but for many of them, they might need another year or two before they transition their endocrine care. And I understand that it's hard to do everything at once. So sometimes, we can kind of talk about what's the timeline going to be and be flexible. There are multiple psychosocial considerations. So of course, a lot of emotions arise around this. I talked a little bit about anxiety, but I think there can also be excitement and hope about it, but also recognize that there may be frustration at times, whether it's frustration on the part of the patient or frustration on the part of the parents, and recognizing those emotions will happen. I think, as Aime said, we have to, all of us, stay patient through the process and provide support. And in a lot of the resources that are available now for families and for providers, one of the key words that people use a lot is encouragement. Really try to just kind of stand behind the patient and help encourage them in this process and be a source of support. And then in terms of the patient themselves, they're trying to establish autonomy, they're trying to establish independence, plus they're also trying to establish trust with a new team. And establishing trust takes time. So there's things they need to do, a patient needs to do between themselves and their parent or their guardian, such as talking about what are the expectations for them and their increased independence. How do they build their self-care skills? At what point do they start ordering their prescriptions or making appointments? And then there's maybe some things that the patient will do with the clinician themselves. So for example, having dedicated time alone with the clinician at the time of a visit, starting to have some time where the parent's not in the room so that you can, as a patient, talk about things with the clinician and get a feel for what that's like, not having the parent there. And then on the far right of the slide, I just wanted to point out some resources through the American Academy of Pediatrics. And then also this gottransition.org, which has a lot of resources, including a toolkit for families and patients. And it's got a lot of kind of nice sort of worksheets, if you will, that ask a lot of the questions or things to think about. And so I would encourage people to use that as kind of a starting point for the transition process. Back to barriers just for a minute, not to be negative, but I just want to kind of point out to any of the young adult or youth patients, one of the things that can be a barrier is the patients just not knowing that much about their disease and not being fully engaged. I think if you're at this meeting, you probably don't fall into this category. You're already showing that you're engaged and you're interested and you're trying to learn. And ThyCa is a tremendous resource and such a great way to learn about the disease, but also be connected with others with the disease. But I think, the idea here is sort of start taking charge and start learning about what it is this disease is and take advantage of the resources that are available to you. So there are, of course, specific considerations to think about related to thyroid cancer itself. And so things that I would just encourage patients to, who are diagnosed at a young age to think about as they move forward are, what are some of the details of their diagnosis? Of course, they may understand, yes, I had, let's say, papillary thyroid cancer, but did I have a subtype of it? Did I, was genetic testing done? There may be some details that are a little hazy to you if you were diagnosed at age 12 or 13. And then once you get to be age 18 or 19, you might start realizing, there's more to this that maybe I should learn about. And I've had that experience where I had a patient diagnosed with diffuse sclerosing variant at, I think, about age 13. I followed her through high school and college. And then when she got ready to transition, she got a copy of her pathology report and she read it and she was panicked. And she contacted me and said, I didn't know I had this type of cancer. I'm really worried about it. I'm reading about it. And how come nobody told me? And we had to kind of step back and say, actually, we had the discussion, but it probably was more with her parents. And she probably just heard I have thyroid cancer when she was 13. And now she's at an age where she's ready to absorb more and understand more about it and needs some education. And I, as a clinician, needed a reminder that we need to talk in more detail with our patients and see where their knowledge gaps might be. So of course, I think it's important to know what was your initial treatment and what was your risk classification? What's your current medication plan? What are your follow-up needs? How often should you be followed? So there's a lot of these details. And that's where I think it's important to have a copy of your records and to know that as a patient, you have the right to have copies of your records. And I think it is helpful. This is one case where I think it's important to print them out and have them in a notebook. But I think now I'm going to talk a little bit about how electronically you have access as well. But just know that you are allowed to have your records, and I think that's important. So I just want to mention briefly the Cures Act, which is taking effect in a couple of weeks. This basically is an act that is designed to provide increased transparency to patients about their clinical record. And so for many of you, if you've already connected through an electronic portal to your healthcare system, you may have already been looking at results and things that come in. But through the Cures Act, it's basically requiring that all of our clinical notes be released to patients and they have access to those. In addition, radiology reports, pathology reports. So a lot more of your records are going to be basically right there at your fingertips that you can pull up the note that I just wrote in clinic yesterday once I sign off on it. So know that those are going to be available to you. And if you have an electronic portal system, you can take advantage of reviewing those. And again, I think it just makes you part of the partner in your own healthcare. A caveat here, there's a lot of nuances with this, but just as an FYI, for people that are 13 to 18 years of age, there are some restrictions because the issue is we want patients to be able to have their records, but we have to think about whether or not parents are allowed to have those records. So there are some limitations in certain age groups. And I won't go into the nuances here, but as providers, we're also kind of learning how this is going to work since it's just about to come online. I show this slide here just to talk about the some of the resources available to us as clinicians as we help people make transitions and sort of make this a more formal process. And one of the things that this handout basically it just is reminding me to mention that at age 18 a lot of things happen, right? You can start voting, but also something called HIPAA comes into effect, and that has to do with how your medical information can be shared or not shared, really. And so in this handout, it's basically informing a patient of that. And what is HIPAA? Well, HIPAA's been in effect since the mid-90s, but it's a law that sets rules for us as healthcare providers, but also health systems about who can look at and receive your health information. And basically the bottom line is you as a patient, when you turn 18, your information is yours and yours alone, but you can choose to share it. You could choose to share it with your parents, but you actually have to provide that permission to us, whether it's in writing. Usually people want it in writing. And it's not an all or none thing. You have the option to choose which parts of your healthcare information you might want shared. Maybe it's fine that I speak with your parents also about your thyroid hormone results, but maybe you don't want me to talk about something else, or you don't want them to talk to your primary care provider about something. So you have the option to choose which things are shared, and you have the option to say, I don't want any of it shared. And so just be aware that that'll be brought up. It should be brought up to you when you turn 18. And it's something that parents need to be aware of. So again, you can set those expectations amongst yourselves. There's a lot more information available about that online. So just to wrap up, transition of care is a process. It involves multiple shareholders, right? The patient sort of at the center of that, but the healthcare system and family and other supports. And I just want to, make you aware that there are resources available online that I think are quite good that kind of give you a launching point as you go through the process. So that's it for me. Let me stop sharing. Okay. So I don't know if we want to answer questions or if we want to have Goli do her presentation and then answer questions. I'll let Pam decide, I guess.
Yeah, and I don't see any questions at all yet. So
okay.
Proceed.
Okay.
Yeah. I've been trying to answer some, and then I think some good things we could address at the end at discussion if we've got the time.
Yeah.
Okay.
I want to make sure Goli gets enough time to go through her talk too.
Definitely. Yeah. Perfect.
Well, thank you, everyone. As it was alluded to earlier, I am a pediatric endocrinologist and oncologist. So the way I like to say it is I bring the good world of hormones to the world of oncology. And one of the areas that I really focus on is addressing endocrine late effects after a diagnosis of cancer during childhood, because that's the most important morbidity that many children who are diagnosed with a cancer and are successfully treated for that actually face. And so what hopefully we're going to be covering over the next 20 minutes or so is talking about monitoring for and treating thyroid cancer in survivors of non-thyroid malignancy, because I think that this is an important area information, and especially it brings in a lot of the key topics that both Aime touched on in her opening presentation and Catherine already covered. So just to really confirm, I have no disclosures, although I do say I'm an opinionated female. That's the only thing I like to disclose, but otherwise I really have no conflict of interest. So essentially, what I wanted to share with you is a typical story of some of the patients that I see in my clinic. And so JD is a delightful young man. I have been seeing him for the past 10 years, and he's a teenager now. And he was diagnosed with a disease called, with a type of cancer called neuroblastoma. He actually had the high risk subtype of neuroblastoma. So he was only 2.5 years old when he actually got this diagnosis. And it was a very harrowing treatment. He doesn't remember a whole lot of it, but obviously his parents will actually never forget that. And as part of that, treatment regimen, he received total body radiation. And so while he finally achieved a successful remission from his high-risk neuroblastoma, part of the 10 years that he and I have been working together as his physician, and he is my patient, is really addressing, unfortunately, a lot of the late effects of that very intense treatment regimen to put his neuroblastoma into remission. And so based on the fact that he'd had total body radiation, and that's an area that we're going to talk about in this presentation, he actually underwent surveillance evaluation for his thyroid. And this is a patient that I see fairly regularly, actually twice a year. I do a physical exam, including examining his neck. But based on some of the concerns that the examination may not be as sensitive to pick up any areas of abnormality, that's why he was a part of our surveillance program for thyroid ultrasound, and that ultrasound actually revealed a 0.8 centimeter nodule. So a tiny small nodule in the left lobe of the thyroid. So I usually like to describe the thyroid as a butterfly to my patients. So the left wing of the butterfly essentially not just had a nodule, but the ultrasound findings were concerning because it had calcifications. And so because of this finding on his ultrasound, I recommended a fine needle aspiration biopsy to get more information. And this actually confirmed the diagnosis of papillary thyroid cancer. So what this really puts in perspective is, as a survivor of childhood cancer, as you actually go on to become a teenager and a young adult, you actually have to face the late effects of your cancer treatment. And a lot of this you may not actually remember, but this exactly points to what Catherine said a lot of times, is understanding what treatment exposures you had as part of that primary cancer diagnosis, because you really have to start advocating for yourself, because many of the late effects will continue on into adulthood. And then this graph that's shown here, both for thyroid nodules and differentiated thyroid cancer, the cumulative incidence for both of these conditions actually increase the farther you're out from your radiation exposure. And it's as it's shown in this panel here in the lower right corner. What we really worry about are those survivors who were exposed to lower doses of radiation. So, and that's the blue line that's here. So as you can see, if it's a low dose radiation, particularly at a young age, the farther you're out, like 20 to 30 years out from your primary cancer diagnosis, that's where the cumulative incidence of thyroid cancer actually increases. And this same concept is illustrated in this slide. So if you look at the risk of thyroid cancer after radiation exposure, what you can see is that this risk is actually linear with the dose of radiation till about 20 sonograys. And then after that, the dose kind of slopes off. And so really what that shows is that it's the dose of the radiation. So if you get really high doses of radiation, that actually kills off your thyroids and not necessarily put you at risk for thyroid cancer, but it's the lower doses of radiation that certainly can cause DNA damage, which is what we worry about subsequent to that, to put you at risk for, different malignancies. And then the other thing that's important to realize is, just with sporadic thyroid cancer, sex actually matters. So females are at a higher risk for secondary thyroid cancer. That doesn't mean that if you're a male, you essentially are not going to be at risk, but it's also understanding that, certainly sex at times can play a role. And sometimes these are important factors to take into consideration for risk stratification of your patients, and to understand who are the ones that you really have to highlight in terms of their risk for subsequent thyroid cancer. And I think lastly, one of the concepts I want to highlight in the slide that kind of pertains to our patient is, sometimes you have to go under treatment regimens where you don't remember at all as a child. And even though the dose of radiation is very small and it's fractionated, such as total body radiation that comes in for either a bone marrow transplant or for treatment of certain solid tumors like the neuroblastoma that this young man had. If you actually get this radiation exposure at a young age, it really makes a difference in terms of when you have your cancer diagnosis. And as it's shown here on the other part of the graph that's enlarged here to the right, if you look at those individuals that were exposed within the first decade of life to this low dose radiation, the cumulative incidence of the curve that just shows of the incidence for thyroid cancer not only goes up steeply with longer time from that radiation exposure, but the curve actually starts pulling itself away within 4 to 5 years. So that's one of the reasons, for example, if you had total body radiation at a much younger age, it's important to kind of keep that into consideration as far as patients were there. But your risk for thyroid cancer is about 25-fold higher. So again, these are individuals who are at significantly higher risk based on their treatment exposure for their childhood cancer. Now, in 2018, the International Harmonization Group, so this was a group that got together with endocrinologists and oncologists, again, pediatric oriented, to really try to come to a consensus. How should we, approach this in our, cancer survivor population, particularly when it comes to adolescents and young adults. And this really was essentially to try to come up with a recommendation in terms of, do you undergo definitive thyroid surveillance with ultrasound, or you actually have physical examination? And so what their final recommendation in this guideline was that this ultimate decision should be patient-centric, but like everything else, the patient should be well-informed. So what does that mean? That basically means that there needs to be a very detailed discussion with the provider, which you have an established trusting relationship, and for that provider and the patient to actually discuss the advantages and disadvantages of either of these modes of surveillance. So, for example, what does it mean to have definitive surveillance with ultrasound, or what about the pros and cons of just having physical examination with neck palpation as a way for surveillance? And then ultimately, based on this discussion, to allow the patient to really make an informed decision. So if the patient were to make a decision for definitive thyroid ultrasound surveillance, that's something that they would continue to go through if a thyroid nodule is identified, and that patient then can be sent to the appropriate specialist to handle that. And then likewise, if you actually, select to have physical examination as a way to detect your thyroid nodule, then you would just wait for that physical examination to reveal the abnormality that subsequently puts you down the way for further evaluation. So this is really part of the International Harmonization Group. But what was very interesting is that this was a split decision. So essentially it was a guideline to provide recommendations, but yet that recommendation was very, in a sense, not necessarily choosing one modality over the next. So why was there a lot of sort of hesitancy for this, guideline recommendation? And I think that this is where sort of the world of specialists like endocrinologists and the world of oncologists, who are the survivorship physicians, kind of had some discordance or disagreement in terms of the benefits versus the negative consequences of doing ultrasound. So one of the concerns was that you basically don't really have a whole lot of benefit if you diagnose thyroid cancer much earlier, because no matter what, it's a very curable cancer. So if you diagnose it earlier with thyroid ultrasound versus letting finally for physical examination to pick up a thyroid nodule, at the end of the day, the outcome is the same. So it's not really going to make any difference. So it's not the same, like breast cancer makes a much bigger difference in terms of when you actually detect that. And then the other big concern was that just doing these ultrasounds, you're just basically going to pick up all these unnecessary thyroid nodules that don't really have any concern, but yet at the same time, you're going to cause a lot of anxiety and stress. It's going to cause inconveniences, additional traveling to, let's say, have additional evaluations. There's a inherent cost to the medical system. And then you're going to put that patient at complication risk because you're recommending unnecessary biopsies or subsequently surgeries because of kind of putting that patient through these definitive ultrasound evaluations. And then the other bigger concern that some of the panel members brought up was that what you're actually doing is picking up, even in the cases that you're picking up thyroid cancer, these are what's called indolent thyroid cancers. So they would have been there, you would have lived with them. They may have never clinically presented themselves. This is a common entity, at least in the adult world. And so essentially what you're doing is you're basically over-treating someone because you're giving them the label of having thyroid cancer, which was in the end something so indolent that if you didn't go looking for it, it's not a problem that you would have ever uncovered. Personally, as an oncologist, I have a harder time agreeing with that, mainly because you're dealing with a host that is a little bit different. So for me, a patient who has been treated with radiation and chemotherapy is a little bit of a different host that I don't necessarily consider a subsequent malignancy as indolent. So, but I think that that was also one of the cases that probably extrapolated from the adult literature. And then lastly, some of the concerns were like, well, maybe you can actually false negatively give, reassurance when there shouldn't be any reassurance. And my, take on that is that this is more of a provider issue rather than a concern for what mode of surveillance do you use, because usually that's where the experts and people and individuals like endocrinologists who are very comfortable with evaluating certainly can be able to, discern what the information is from the thyroid ultrasound. So in terms of what are the ways to think about this, so at the Children's Hospital of Philadelphia, and certainly as part of some of the thyroid endocrinologists that are part of this panel and also as part of this conference, I think there are many of us who are actually more proactive in terms of using thyroid ultrasound as a definitive way, especially in patients who are at risk for subsequent malignancies. And so some of the counter arguments to think about to the information that I presented earlier or the last slide is that there's actually benefits to early detection of treatment. And I think that that's a very important concept for us to think about. And, like anything else, cancer is a genetic disease. And so when you develop thyroid cancer after radiation, that genetic rearrangements that are seen in the thyroid cancer tumor can be a little bit different. So that blueprint, that genetic blueprint is a little bit different. And actually that does have an effect on the outcome. And I think that those are important for us to take into consideration. Now, earlier was alluded to that in 2015, the American Thyroid Association actually convened a task force. Dr. Bauer, Dr. Wagesbach were part of this task force to really come together and provide management guidelines for children and adolescents with thyroid nodules and differentiated cancer. And really the goal of this guideline was to provide a risk stratified approach. So it's not a one size fits all. Not every patient with a thyroid cancer diagnosis in pediatrics should have the full shebang as far as surgery and radioactive iodine, et cetera. So I think that that's why the ATA pediatric guidelines is really important in terms of how we approach pediatric patients for treatment. But I do think the pediatric ATA guidelines also highlighted a few important concepts that we can extrapolate. So one is that differentiated thyroid cancer remission increases with earlier detection. So I think that that is a very important concept, especially as risk of recurrence can also be higher in pediatric patients. And then earlier detection basically results in less aggressive means of treatment. And I think that that also then results in less complication risks. So for me, that's important. If I have a patient who's had neck radiation, that's going to be a much harder field, even in the hands of a very experienced surgeon. Still you're going in a neck that things can be very complicated, especially after having had radiation history in the past. And I think one thing that's really important to realize is that majority of patients with differentiated thyroid cancer have excellent prognosis. So cure alone really is not what we need to focus on. So I know that that's the oncology mentality, is that you really focus on cure. To me, this is a cancer where cure alone is not enough. What you really need to demand is cure with limited morbidities and late effects. So that really is sort of the bar that we should set for ourselves to meet, not just to say, well, the patient is cured, so therefore we're reaching the goal that we want. Again, the benefits of early detection is that the earlier you detect, particularly in pediatric patients, you have lower rates of recurrence, which again, this is really important, and especially also I highlight from a psychological perspective in patients who not just have the C word the first time, and some of them may not remember that, but diagnosing cancer for a second time in a survivor actually can be incredibly distressing. And I think one of the most important components is to really be able to achieve a remission and just really make sure that the recurrence rates are about as low in terms of really helping overcome a lot of the stress and anxiety that's associated with that. And again, the later you diagnose cancer, especially if you wait with physical exam alone and you find a nodule, that's more of a risk for that nodule to be, metastasize and just have the need to do extensive surgery to be able to achieve what you really need to, achieve for that remission. And again, you can have the most experienced surgeons, but even in the hands of very experienced surgeons, the more infiltrative and extensive bulk disease that you have, the higher risk you have for some complications like hypoparathyroidism. So I think that those to me are very important concepts to think about. And probably the most important motivator for me as an oncologist who is really focused in this area is that early detection actually can obviate the need for radioactive iodine. And why is that important? Well, you can certainly get secondary malignancies from radioactive iodine alone. And that obviously has to do with the cumulative dose, but essentially what you can have is other cancers as a result of getting exposed to radioactive iodine. And some of that, for example, can increase your risk for leukemias, or solid cancers like breast cancer, stomach cancer, salivary tumors, and renal tumors. But for me, what I really worry about is you're taking this risk and you're superimposing it in a host that already had types of chemotherapy, such as alkylating chemotherapy exposures and radiation exposure. So we already know that a survivor of childhood cancer is a subsequent risk for malignancies. And so therefore, to me, not having to give radioactive iodine is a real incentive in these patients, particularly as it obviates, or it reduces their risk for subsequent malignancies. So that to me really is one important motivating factor in terms of active surveillance in a way to detect this cancer at a much earlier age, where surgery alone can induce the cure that we are looking for. And I do think it makes a difference. So what we do know, for example, is that if you develop a second malignancy due to radioactive iodine, your survival actually is going to be a lot lower. So, again, while the number of patients are not very high, so again, this is not a problem that we see on a fairly regular basis, but I do think it highlights the importance that if you are developing a second cancer because as a result of radioactive iodine exposure, your overall survival can certainly be limited. And I think that this is also similarly shown in this slide, where if you are a childhood cancer survivor and you develop thyroid cancer, so second thyroid cancer, compared to a teenager or an adolescent young adult who has developed primary thyroid cancer, the survival curves are a little bit different. So again, overall, it's still very excellent. We need to highlight that, but still there is a slight difference. And I think a lot of this kind of goes back to you're dealing with a host that has more vulnerabilities because of the treatment exposures from their first cancer. So I think that those to me are important motivating factors. But the other, I think, very important concept to think about is the genomic landscape. So the blueprint of the thyroid cancer that you see after radiation. And I think the world of oncology has really changed as we are incorporating the genetics of the tumor. And I think that this is equally as important for thyroid cancer. And so some of these gene rearrangements that you can see in papillary thyroid cancer, which is the most common type of cancer you see after radiation, is something called a RET-PTC fusion. So normally in adults, you only see this about 15% of the time in the papillary thyroid cancer tumors. But this is a little bit more common in pediatric patients who develop thyroid cancer. So that can be as high as, half of pediatric patients. We can certainly see that. But what's more important is that if you've had radiation exposure, a much higher percentage of these tumors actually have, these gene rearrangement that's really reflecting the DNA damage from radiation. And I think that this is sort of illustrated as far as the learning lessons from individuals who were exposed to environmental radiation. And I think Chernobyl and Japan and Fukushima have a lot to teach us. So in Chernobyl, with the nuclear reaction accident that happened, as you can see, compared to if you want to look at just children sporadically having thyroid cancer, the gene rearrangements in about a third of those patients. But in the children after the Chernobyl accident because of radiation-induced thyroid cancer, that number of gene rearrangements was as high as 85%. So again, a lot more of these gene rearrangements. And same thing as Japan and Fukushima, although I think one thing to really highlight the difference, for example, between Chernobyl and Fukushima is that in Fukushima, the radiation exposure was actually not anything above ambient environment. So even despite the the accident, the overall radiation contamination of the environment was a lot lower than what a lot of the individuals who lived in Belarus actually experienced. So I think that this is all important. Why? Because gene fusions actually can show up in terms of having or be associated with more aggressive and invasive tumors. So what we do know is that gene fusions, for example, the RET PTC, can be associated with certain subtypes of papillary thyroid cancer, like diffuse sclerosing variant or the widely invasive follicular variant PTC. So these are, these blueprints actually do predict that this is going to be a far more invasive and aggressive tumor, which in and of itself is an incentive why it's best to pick up this cancer at a much earlier age rather than wait for it to be detected by palpation, where it's had more of a chance to, invade important structures in the neck, as well as have, distant metastases. And I think the other thing that we learned from Belarus, for example, is that the risk of thyroid nodules in children and adolescents actually, directly correlates with the dose of the radioactive iodine exposure. So I think that linearly, correlates with that. And then more importantly, that if you actually look at the nodules, whether you have small or large nodules, the risk of malignancy is essentially the same. So that to me is also an important concept to realize, that a small nodule that may not be palpated on physical examination can equally have risk for thyroid malignancy. So size alone is not what's going to be driving that in terms of, detection. And I think that the studies through Belarus and Chernobyl, where they actually took patients and did a surveillance study with endocrinologists and providers who actually were trained how to physically, do a palpation. What we ultimately found based on those study results is neck palpation actually has a low sensitivity, for detecting a thyroid nodule. And then again, I go back to the patient I presented earlier that, this young man had physical examinations on a, regular basis, but his nodule was actually very small. And even in some of the additional patients, sometimes you actually cannot pick these nodules on physical examination alone. So I don't think even in the hands of a very experienced provider, it's never 100% guarantee. Some of the other lessons we learned that I think is important in terms of how you provide your guidance and recommendation is that there's a latency. So just because you had radiation doesn't mean that you have to worry about your other, cancers like the thyroid cancer risk the day after radiation or shortly after your radiation exposure, but rather there is latency. So it's usually the longer you are from your radiation exposure. And this to me is actually one of the most important teaching points that I find, giving my survivors, because a lot of times they may not have awareness of their radiation exposure as being young, but actually their risks for that second malignancy is going to be much higher as they're going to be advocating for themselves in the adult health system. So I think that that's why it's really important in terms of why you need your care with survivorship physicians, or at least physicians who really focus on the late effects from the primary cancer treatment. And the other thing that we've learned, or at least Belarus taught us, that if you did not do the surveillance, essentially what you had is patients who presented with fairly extensive disease. And so once they instituted these surveillance programs, there were far less extensive disease burden in terms of bulky neck disease or, metastatic disease. So that's one of the benefits of, instituting screening protocols, particularly in a group of patients with high risk exposure, which, again, it kind of highlights why sometimes you really, really need to step out and think outside the box. And I think that kind of brings me to the second point in terms of the counter argument for some of those concerns that have been raised against using definitive ultrasound surveillance, is that you can actually get very sophisticated with this. You can use prediction models that actually can take your survivor with their, treatment history based on their sex, whether, they've had prior nodules before, the kind of chemotherapy exposure, and you can actually risk stratify those survivors. And then you can basically present that based on this model, this is your risk, and then, subsequently use that. So you can certainly get more sophisticated in terms of using that information to your advantage. I think there are better tools and technology that in the hands of the right provider, that these can actually help mitigate coming to decisions in terms of, erroneously recommending biopsy when it's not necessarily needed. And I think the most important thing is that if you actually have nodules, that the biopsy is not conclusive, instead of just recommending that patient to go to surgery where it may end up being unnecessary, is that you can actually incorporate genetic testing of that nodule to eventually come to the right decision. And I personally find that this is incredibly helpful, where it has provided guidance, and we have really prevented unnecessary surgery in some of our survivors who were equally at risk based on their radiation exposure in the past, but the nodule really ultimately did not, have evidence of malignancy based on the oncogene, testing. So again, thyroid ultrasound is really the gold standard for detecting thyroid nodules. It's a very sensitive and specific way, so far more sensitive than a physical exam and palpation. It's pretty cost effective, I think, compared to CT scans and MRIs. It's non-invasive. You don't need IVs. You certainly don't need to be sedated, and it's a modality that's really well studied in children. And the recent advances really have a much higher way, a better way of diagnosing thyroid malignancy, even in children. So it's not just extrapolating the adult data to pediatric patients. And then lastly, as I alluded to earlier, I think this is where you can really bring the technology and make your practice more evidence-based. And that's really incorporating oncogene testing into your clinical practice. So a lot of this information will help guide you, so you're not unnecessarily putting patients through a surgery just because the biopsy results were inconclusive. And I think that particularly is helpful for patients, especially survivors who may be at an extreme risk of anxiety in terms of, oh my God, this nodule, if it's inconclusive, then I just need to go to surgery. That may not really be necessary, because you can appropriately give them the assurance with the test that gives you the information. So I think with this, I hope over the course of the last 20 minutes, some of the things that we talked and learned about the importance of early detection of second thyroid cancer as far as its benefits in survivors of childhood cancer. It really helps towards increasing remission and reducing recurrence rates. To me, those are very critical elements, reducing the surgical morbidities, and obviating the need for radioactive iodine, and really reducing the risk for second malignancies. And then it really kind of helps us incorporate the information that we learned, for example, from Chernobyl and the high-risk population, in terms of the importance of using active surveillance. So I think that's why we need to use the history to really provide us with better guidance in terms of caring for our patients today. And then again, not to be static, is just, embrace the change and incorporate the new technology, and more importantly, the advent of genetic testing. And a lot of that, you really need to sometimes it's not just one provider, you just need to have a multidisciplinary group of providers. And that, to me, is modern day medicine, where one person may not necessarily be able to have all the answers, but that, I think, is one of the benefits of being in centers where you can really rely on your colleagues with multiple expertise. And so with this, I wanted to thank you for the time that you spent, and hopefully this information was helpful. I think going back to the patient story that I presented earlier, he actually did really well. He underwent total thyroidectomy, so his thyroid gland was removed. Thankfully, he had no evidence of spread of thyroid cancer to his lymph nodes, and he actually recovered from that nicely. He did not need radioactive iodine, and currently he's a senior in high school and applying to colleges, and hopefully he's going to get a basketball scholarship. So with that, I wanted to thank all my colleagues, at the Children's Hospital of Philadelphia, where is the mothership, and certainly we would not be able to provide the care where science and clinical expertise intersect. I think that's one of the benefits of having someone like Aime Franco, who not only has a personal experience with thyroid cancer, but she really brings the science and from bench to bedside, where we really can make a difference in terms of patients' care. And I think that for me, as a provider who really focuses on the care for childhood cancer survivors, this is where I feel like the some of the state-of-the-art ways that we treat patients has really benefited the care that we give to our cancer survivors, which I always say that cure alone is not enough, but actually what you need is cure with a high quality of life. So with that, I thank all of you, and certainly happy to answer any questions.
Okay. Thank you very much. It looks like we may have only about 2 or 3 minutes for some questions, and then Zoom is going to kick us off. But if anybody wants to raise their hand, ask a question in the chat box. We have one question regarding recommendations of getting a genetic test of a nodule that is noted as inconclusive. If a patient has already had genetic testing of multiple genes, would this be a different genetic test for an actual nodule?
So the answer to that is, if you've had genetic testing for what's called like your germline, that's a little bit different. What we're really referring to is testing the genes of the nodule, so that the genes that are present in the cells for that nodule. And that if you find the typical mistakes or what we call mutations that you see that are associated with thyroid cancer, that's when you can actually definitively diagnose that thyroid nodule as malignant versus benign. So that's really the benefit. So it's a different type of a genetic testing, if you want to think about it. It's just really using these panels to pick up the kinds of mutations that you see usually in thyroid cancer.
One thing I wanted to just kind of hit on really quick based on some of the questions that I was trying to answer as we were going through is, I think as you can see, there's a big discrepancy between how thyroid cancer patients are treated versus how childhood cancer patients are treated, because those of us in thyroid cancer almost never get to an oncologist. And I think that's where one of the things, we have flow throughs and we have all these great charts for survivorship and transition of care in oncology, but we don't have it in thyroid yet. And I think that for me personally, as I went through my own cancer diagnosis, was something that was so strange, and those around me couldn't understand as well, why aren't you in an oncologist? And not realizing that thyroid cancer is treated differently. And because we don't go through chemotherapy in the ideas of the same kind of chemotherapies that those with other tumors go through. So I think that was something that was very challenging for me. And I think also why I hate to say behind, but we are a little bit more behind than we are in oncology in general, because some of these things have been going on for years and we're just now starting to bring it into the thyroid realm. And I think it's because of patients, and patients have been demanding it, and it's been great. So continue to engage and be involved in this, and be involved in research. Consenting, it doesn't mean your tumor necessarily has to go somewhere, but even just knowing your medical history can be used for research. So.
Okay. We've run out of time, unfortunately. So thank you everybody for coming. Thank you very much for joining.
Thank you.
Thanks everybody.
Thanks everyone.
Bye-bye.